Hello and welcome to the Tompkins Nurse Pro Academy. Today we shall be presenting on cardiovascular disorders in pediatric population. As always, my name is Thomas and Aaron, and today I'm excited to take you through this essential topic. This topic has been tailored for the healthcare providers with a special focus to the nurses. My fellow nurses, guys, in this session today, we will cover common congenital and acquired cardiovascular disorders in children, their pathophysiology, clinical presentation, diagnosis, and management. And don't worry, we're going to be throwing in some nursing-friendly mnemonics that are going to help us keep moving. So let's get started. So before we jump into the disorders, we need to do a quick review of the anatomy and physiology of the cardiovascular system. So just generally, we know that the heart is a four-chambered muscular organ that is responsible for pumping oxygenated and deoxygenated blood throughout the body. We have the right atrium, and this one, its role is to receive deoxygenated blood from the body via the superior and inferior vena cava, while the right ventricle on the right side of the heart will be pumping deoxygenated blood to the lungs for oxygenation via the pulmonary artery. Left atrium, on the other hand, you find that this auricle will be receiving oxygenated blood from the lungs after oxygenation via the pulmonary veins. Then we have the left ventricle, which is going to be pumping oxygenated blood to the body via the aorta. When it comes to the valves, we have the four valves, right? So we're starting with the tricuspid valve, which is found on the right side and is found between the right atrium and the right ventricle. The pulmonary valve is found between the right ventricle and pulmonary artery, while the mitral valve, also referred to as the bicuspid valve, will be found between the left atrium and the left ventricle. Lastly, aortic valve will be found between the left ventricle and the aorta. So in general, guys, when you're trying to compare the heart, the cardiovascular system of the adult vis-a-vis the pediatric one, you find that the pediatric one is smaller, but proportionally it's larger relative to the heart size. So you find that although the pediatric heart is small compared to the adult, if you look at the percentage of body covered by the heart, you find that the small one in Peads covers a relatively larger area compared to the adult one. You find that cardiovascular system in Peads, we have walls which are very thin and more flexible, and they are more compliant, so they are less rigid like adults, and this one allows greater adaptability to circulatory changes. There is also low risk of calcification of the valves, except maybe when you have a congenital disorder. And these ones, they are more dynamic, the heart is more dynamic and adapting to transitional circulation, that is post-birth. Lastly, congenital disorders like bicuspid aortic valve or mitral can occur in such a population. So we also need to remind ourselves about fetal circulation vis-a-vis the postnatal circulation. So as you all know, that during fetal circulation or fetal life, the cardiovascular system is adapted to bypass several vital organs, like bypassing the lungs. The role of the lung is to make sure that the blood is oxygenated. But you find in a pediatric or in a fetus, oxygen is provided by the placenta. So there is no need of blood getting into the lungs. But we have some fetal circulation adaptations that will facilitate this bypassing of the lungs, bypassing of the liver, right? So the first one, we have the foramen ovale. Foramen ovale is a hole between the right and left atria. This one normally allows oxygenated blood from the placenta to bypass the lungs. Number 2, we have the ductus arteriosus. Ductus arteriosus is a connection between the pulmonary artery and the aorta, and this will allow shunting blood away from the lungs. So instead of blood going to the lungs via the pulmonary aorta, the pulmonary artery, I beg your pardon, it will just flow direct to the aorta, right? So there is no need of oxygenated blood, is already oxygenated for this population. Another special structure is the ductus venosus. This is a vessel that allows oxygenated blood from the placenta to bypass the liver and enter the inferior vena cava. So generally we have umbilical vein, which is one, and this one carries oxygenated blood from the placenta to the fetus, bypassing the liver via the ductus venosus to the heart. And we also have the umbilical arteries, which are two. These ones, they carry deoxygenated blood and waste from the fetus to the placenta for the exchange. Remember, umbilical arteries, they normally arise from internal iliac arteries, and they will help in transporting waste to the placenta. And these are the internal iliac arteries. You can be able to see it on our diagram, right? On our diagram. This is where the umbilical arteries will be emanating from. So we have some changes that normally happens at birth, okay? Circulatory changes following birth. So now you need to know that after birth, when the baby takes the first breath, they are going to cause the lungs to expand, and when the lungs expand, it decreases pulmonary vascular resistance. Foramen ovale is going to close. Remember, foramen ovale was connecting the atria, that is the right atria and the left atria. So at birth, the foramen ovale is going to close, and this is going to prevent blood from bypassing the lungs. So the blood will be directed to the lungs. We also have ductus arteriosus. Ductus arteriosus, it's going to constrict, and this is going to help direct blood also to the lungs. And lastly, ductus venosus, which is going to close to ensure that blood now flows through the liver. So physiological differences in pediatric population we can easily summarize as follows. That the newborn's heart is relatively larger compared to their body size as compared to the adults. So like looking at the newborn's heart and the body size of that neonate, the newborn's heart is relatively larger compared to when you compare the size of the adult heart and the size of an adult. The left ventricle is undeveloped at birth, and it will strengthen as the child grows. Newborns have a higher heart rate, so it's about 120 to 160 beats per minute, right? That's why when somebody joked saying that a baby's heart beats so fast, it's like it's constantly trying to break the world record for tachycardia. But you don't need to worry, because it is going to slow down as the child grows, right? As the child grows, it's going to slow down. On stroke volume, the pediatric population is going to present with a low stroke volume. So cardiac output is going to depend majorly on the heart rate, and that explains why most of them are going to have elevated heart rate if you're trying to compare it with adults, right? Lastly, we have the cardiac output. Cardiac output, remember, we normally take the heart rate times stroke volume, right? So in this population, cardiac output is maintained primarily by the heart rate rather than stroke volume. Remember, we had already said that the stroke volume is reduced in this population. In terms of blood pressure is lower at birth due to decreased peripheral resistance and increases gradually as the vascular resistance develops with age. For the oxygen demand and circulatory adaptation, this population normally presents with higher metabolic rate, right? And this normally increases oxygen demand. So they have the fetal hemoglobin, which will be present at birth, and this one has a higher affinity for oxygen, but it will shift to adult hemoglobin at about 6 months, right? About 6 months. So in summary, we have larger neonates are larger in proportion to body size. Their hearts are larger in proportion to the body size, so they're about 0.8 of the body size. When in adult is about 0.4, so it's almost double. Right and left ventricles are nearly equal in thickness at birth, but the thickness for the left is going to increase as they age. Heart rate is higher, we have already explained that, and cardiac output is dependent on the heart rate rather than the stroke volume. Oxygen demand results in higher metabolic rate, which means that they have a higher oxygen demand, right? Features, remnants of fetal circulation, we have talked of ductus arteriosus, foramen ovale, which may still be closing in some patients. So these cardiovascular disorders in pediatric populations are broadly classified into two, right? We have acynetical and synetical, right? So when you talk of acyanotic congenital heart disorders, in this particular kind of population, you find that there is no cyanosis, and the shunting is normally left to right shunting, right? Left to right shunting. The other one is cyanotic, congenital heart disorders, whereby these ones will present with the cyanosis, and then the cyanosis will be present at birth, and the shunting is usually right to left shunting, right? That will be involved in this case. So generally, cardiovascular disorders are divided into two. We have the congenital one and the acquired one, right? So the acquired will be present at birth, while the congenital one will be present at birth, while acquired will develop after birth. So we have several top 10 disorders, right? Starting from the congenital heart disorders, right? Which you have said some could be acynetical or cyanotic, right? Cyanosis will be present at birth, and the shunting is right to left. While the acynatical, we're saying that there will be no cyanosis at birth, and the shunting is left to right, right? Left, right, after oxygenation has taken place. So we have several disorders here, congenital, rheumatic, and we are going to be looking at one after the other one. So let's start with congenital heart conditions, which you have already said can be acyanotic, where there is no cyanosis at birth, or cyanotic, where we're going to have cyanosis at birth. So the shunting here is normally left to right, while here it is right to left, so oxygenation is affected. The acyanotic disorders do not cause acyanosis because oxygenated blood is still delivered to the body, but may lead to heart failure due to volume or pressure overload. Some of the examples of these disorders include ventroseptal defect, atrial septal defect, ductus arteriosus, coarctation of the aorta, pulmonary stenosis, and aortic stenosis. So we have 6 major acynetical disorders that do not cause cyanosis. Remember, the shunting is usually left to right after oxygenation has already taken place in the lungs. So the most common one is ventral septal defect. That's why somebody joked and said that this is a very strong defect, right? Very strong defect. Because the left ventricle is too strong and forces blood into the right, right? Very strong disease. So remember, the shunting here is left to right, right? Left to right. So this congenital defect is characterized by abnormal opening in the interventricular septum. This one will allow blood flow between the left and right ventricles. It is the most common congenital disorder. That is what you need to know. And here there will be a hole between the ventricles. Notice on our diagram, there is a hole between the ventricles. And since we have more pressure on the left than the right, blood is going to flow from the left ventricle to the right ventricle. Remember, oxygenation had already taken place, so it might not cause cyanosis as such. We have four major types of ventroseptal defect. We have the membranous ventroseptal defect. So this membranous ventroseptal defect is located in the upper portion of the septum near the aortic and the tricuspid valve. So this is the most common type of ventroseptal defect. We also have the muscular type, which this one is found in the lower thick muscular layer of the septum, and this one can close spontaneously. The third one is the inlet ventroseptal defect. This one is near the tricuspid type valve and the mitral valve, and is often associated with other atrioventricular septal defects, right, of the body. Lastly, we have the outlet or the supracrystal ventroseptal defect. This one is located near the pulmonary and aortic valves in the Asian population, right, in the Asian population, and you can be able to see it here. Pathophysiology of this disorder. So normally the left ventricle has higher pressure than the right ventricle, that we all know. But in a ventroseptal defect, this one is going to allow oxygenated blood from the left ventricle to flow to the right ventricle. So we're going to have left to right shunting. Also, we're going to have increased pulmonary blood flow, which leads to pulmonary congestion, volume overload, and eventual pulmonary hypertension. When you have a large and uncorrected ventroseptal defects, this can lead to what we refer to as the Acyanotic syndrome, where we're going to have reverse shunting from now the right to the left. And when this one happens, it's going to result into cyanosis. So some of the clinical manifestation, the most common one include shortness of breath, fast breathing, hard breathing, paleness, failure to gain weight, fast heart rate, and sweating while feeding. Right? Remember, at late stage Acyanotic syndrome might occur, and this could lead to cyanosis. Yet we've said that acyanotic conditions do not present with cyanosis. But in case we have this complication of the Acyanotic syndrome, it is going to result into cyanosis. So diagnosis of ventroseptal defect, we have echocardiography with Doppler, which is going to confirm the size, location, and the shunting pattern. Chest X-ray, which may show cardiomegaly and increased pulmonary vascular markings. ECG, which may indicate left ventricular hypertrophy or right ventricular hypertrophy. Cardiac catheterization, which is used in complex cases to assess pulmonary pressures. On the management, if it is just a small ventroseptal defect, it just requires regular monitoring, and mostly it can close approximately by age 2. As for the medical management for these symptomatic patients, we could use the diuretics like the furosemide, which is going to reduce pulmonary congestion. Angiotensin converting enzyme inhibitors like captopril, enalapril, which are going to reduce afterload and cardiac workload. Digoxin, which may relieve symptoms if other treatments do not work. And we also have nutritional support, where we encourage high calorie, which needs high calorie feeds, especially for the failure to thrive babies, right? So remember, when it is large, you need surgery between the 3rd and the 6th month of age. If it's just moderate, either surgery or device closure, and small, they just need follow-up, and hopefully they can close spontaneously by age 2. Complications of ventroseptal defect. We have pulmonary hypertension, which is increased pulmonary resistance, Eisenmenger syndrome, and this is irreversible cyanotic condition due to now right to left shunting, aortic regurgitation due to prolapse of aortic valve, endocarditis due to the risk of infection in the abnormal septal region, arrhythmias due to ventricular remodeling. So we are done with the first condition on the ventroseptal defect. Remember, we were looking at acyanotic congenital defects that do not cause cyanosis and are resulting from the left to right shunting. So the first one we have looked at ventroseptal defect. So I will suggest that you pause the video and you go and attempt the quiz on the ventroseptal defect to test your understanding of this condition. The second condition here, we're going to look at atrial septal defect. And this atrial septal defect is a congenital heart defect characterized by abnormal opening in the interatrial septum. And this is going to allow blood to flow between the left and right atrias. This results into left to right shunt, and this will increase pulmonary blood flow and potentially leading to the right heart overload. It leads to left to right shunting, increased pulmonary blood flow, and right-sided heart overload. Right heart-sided overload. Somebody joked that atrial septal defect is a silent shunting disease because mild cases normally go unnoticed for months, right? So just like we looked at the types of ventroseptal defects, we also have types of atrial septal defects. So we have the ostium secundum. Ostium secundum is located in the central portion of the septum, and this is the most common type of atrial septal defect. Number 2, we have the ostium primum atrial septal defect. This is found in the lower part of the septum and is associated with atrioventricular septal defects. The third one is sinus venous atrial septal defect. This occurs near the superior vena cava or inferior vena cava entrance. Lastly, we have the coronary sinus. It's a rare defect where the coronary sinus is partially or entirely enroofed. So those are the 4 major types of atrial septal defect. So normally the left atrial pressure is higher than the right atrial pressure. So this defect causes left to right shunting, increasing the right atrial and right ventricular volume. So over time, the right heart dilatation, increased pulmonary blood flow may lead to pulmonary hypertension. If untreated, severe cases can also progress to Eisenmenger syndrome, just like the ventroseptal defect, so whereby the shunt will reverse so that it is now right to left, and in that case, is going to result into cyanosis. So if there are small atrial septal defects, the patients will be often asymptomatic, and these defects may close spontaneously. But if they are moderate to large atrial septal defects, patient could present with fatigue, exertional dyspnea, frequent respiratory infections in childhood, fixed, widely split second heart sounds. This is mainly due to prolonged right ventricular systole. We also have systolic ejection murmur at the left upper sternal border due to increased pulmonary blood flow. We also have atrial arrhythmias, e.g. the atrial fibrillation or flutter in older children or adults. And the patient could also have Acyanotic, where is going to have a reversal of the shunting. Instead of left to right, now we're going to have right to left, and that normally causes cyanosis. We also have paradoxical embolism, where a thrombus forms in the right atrium and enters the left atrium via the patent foramen ovale. So what are the diagnoses? How do you diagnose atrial septal defect? Someone asked, which one of the following diagnostic tests is the most commonly used to confirm the presence of an atrial septal defect? Well, the answer should be transthoracic echocardiography with Doppler. So we have echocardiography with Doppler, which confirms the defect size and shunting direction. We also have the bubble contrast echocardiography, which is used to detect small defects or patent foramen ovale. ECG, so it may show the right axis deviation, right bundle branch block, or atrial enlargement. Chest X-ray may show right atrial and right ventricular enlargement with increased pulmonary vascular markings. Then cardiac MRI or CT, for this one will be used for detailed anatomical assessment in the complex cases. Treatment, of course, small one, they often close spontaneously, so this one they require regular monitoring. Medical management is for these symptomatic cases. So we could have diuretics for pulmonary congestion, antiarrhythmics for atrial fibrillation or flutter developing. Also, antibiotic prophylaxis this one is not routinely required except for some conditions of previous endocarditis. So what are some of the indications of the closure of this atrioceptal defect? So if this defect is more than or equal to 6 millimeter and is persisting beyond 2 to 3 years, will have to be closed. Could also, another indication is right ventricular volume overload and symptomatic patients, like patients presenting with dyspnea and arrhythmias. So what are the closure options? We could do the transcatheter device closure. This one is preferred for the secundum atrial septal defects. And we also have the surgical patch closure. This one is for large or complex defects like the primum or the sinus venosus. Complication of untreated atrioseptal defects. We could have right heart failure, and this is due to chronic volume overload. Atrial arrhythmias, and this is due to increased risk of atrial fibrillation or flutter. We also have pulmonary hypertension, and this can progress to irreversible Eisenmenger syndrome, where we're going now to have reversal shunting. Remember, atrioseptal defect, the shunting is from left to right. But with the Eisenmenger, the defect, the shunting will now be from right to left, and this is going to result into cyanosis. Paradoxical embolism. So the risk of stroke, if there is a right to left shunting, will develop, right? Will develop when there is a right to left shunting. Lastly, echocarditis, although this is very rare, not common in this particular patient, but can occur. Right, guys, so we are looking at acyanotic congenital heart disorders. We have already looked at VSD. We are now looking at ASD. So we could also pause the video and attempt the free quiz on atrial septal defect just to test you understanding of that lesson. The third conditions under the acyanotic congenital heart disorder is the patent ductus arteriosus, abbreviated as PDA. PDA is a congenital heart defect where the ductus arteriosus, where did we have the ductus arteriosus? Remember, these are fetal blood vessels that normally connects the pulmonary artery to the descending aorta, right? So in patent ductus arteriosus, this vessel fails to close after birth, and this leads to abnormal left to right shunting of blood. So instead of blood going directly to the body via the aorta, it goes back to the pulmonary artery, right? So persistence of the ductus arteriosus, which normally closes after birth, this is what is going to result in this PDA. PDA causes blood to flow from the aorta into the pulmonary artery. Remember, in fetal life, the ductus arteriosus allows oxygenated blood from the placenta to bypass the lungs. So after birth, rising oxygen levels and decreasing prostaglandins typically trigger the closure of these ductus arteriosus. However, in patent ductus arteriosus, persistent patency will result into blood flowing from the aorta, which has high pressure, into the pulmonary artery that has low pressure compared to the aorta. And this normally results into increased pulmonary blood flow, which is going to lead to pulmonary congestions and edema. We also have left atrial and left ventricular volume overload, resulting in left heart failure over time. And lastly, risk of pulmonary hypertension and Asen syndrome if left untreated. Risk factors for patent ductus arteriosus include prematurity, which is the most common cause. You find preterm infants have higher prostaglandin levels, leading to delay in the ductal closure. Maternal rubella infection during pregnancy also affects fetal heart rate development and can result into patent ductus arteriosus. Low oxygen levels at high altitudes can delay the ductus arteriosus closure. Conditions like neonatal asphyxia and respiratory distress syndrome increase prostaglandins, keeping the ductus open. Patent ductus arteriosus is closely associated with Down syndrome, CHAD syndrome, and other congenital heart defects. So if kids are presenting with these other disorders, they could be suffering from also PDA. PDA is more common in females than males, and also exposure to teratogens like alcohol, anticonvulsant, and maternal diabetes also increase the risk. Low birth weight babies, that is less than 1500 grams, have a higher incidence of patent ductus arteriosus. So small PDA, these patients often are asymptomatic, while moderate to large patent ductus arteriosus patients, they will present with machinery like continuous murmur at the left infraclavicular region. They also present with bounding pulse, that is widened pulse pressure, and this is due to increased systolic pressure and decreased diastolic pressure. Patients could also present with signs of heart failure like tachypnea, poor feeding, and failure to thrive. We also have patients presenting with frequent respiratory infection, and this is due to pulmonary congestion. And lastly, patient could also present with cyanosis, especially in complications like the Eisenmenger syndrome, which normally affects lower limbs more than the upper limbs, right? Okay, so there's a question here, differential cyanosis. Cyanotic lower limbs but pink upper limbs in PDA suggests, yes, complication of or the complication leading to Eisenmenger syndrome, right? So this one shows that there is a reversal of shunt due to pulmonary hypertension, so that the shunt is now occurring from right to left, right? And this is going to lead to cyanosis, right? We can diagnose these conditions by echocardiography with Doppler, which confirms the presence of PDA and assess shunting, chest X-ray, which shows cardiomegaly and increased pulmonary vascular markings in large PDAs, ECG, which may show left atrial and ventricular enlargement, and cardiac catheterization, which is rarely needed but can be used in complex cases. Medical treatment for premature infants, you would use the indomethacin or ibuprofen. These are just NSAIDs. NSAIDs are going to inhibit prostaglandin synthesis, and this one is going to promote closure. Interventional treatment like the transcatheter closure with a coil or a device, this one is preferred for older infants and children. Surgical ligation or diffusion reserved for large PDAs or cases where catheter-based closure is not feasible. Supportive therapy, which aims to manage symptoms and reduce complications while awaiting spontaneous closure or definitive treatment. Use of diuretics for symptomatic infants with heart failure. And lastly, high calorie feeds for growth support in affected infants. Complications of patent ductus arteriosus includes heart failure, pulmonary hypertension and Eisenmenger syndrome, endocarditis, and growth failure and recurrent respiratory infections. So ladies and gents, we've come to the end of that presentation on patent ductus arteriosus. You could also attempt the free quiz on the same condition. The fourth condition under the acyanotic congenital heart defect is coarctation of aorta, COA, right? Okay, this is a congenital disorder characterized by narrowing of the aorta and typically occurs near the ductus arteriosus, that is the juxtaductal region. This condition normally leads to obstructed blood flow from the left ventricle to the lower body, causing hypertension in the upper parts or extremities and reduced perfusion in the lower extremities. So narrowing of the aorta leads to increased workload of the heart. Remember, someone was joking that coarctation of aorta patients are like weight lifters. They have upper body strong and lower body weak, right? That is what you need to remember. So narrowing of the aorta normally increases afterload on the left ventricle, leading to left ventricular hypertrophy. Blood pressure is elevated proximally, that is in the head and the upper limbs, and reduced distally in the lower limbs. Over time, collateral circulation develops via the intercostal arteries, which can cause rib notching on an X-ray. If left untreated, coarctation of aorta can lead to complications like heart failure, aortic rupture, and stroke. Coarctation of the aorta is most commonly occurs at which anatomical position? This is a common question, and the answer you should know is that at the arc of the aorta near the ductus arteriosus, right? Ductus arteriosus, where we have the pulmonary artery connecting to the aorta. So we have types of coarctation of aorta. We have the preductal one, the infantile type. This one, it is characterized by narrowing of the proximal end of the ductus arteriosus. Okay, it's more associated with conditions like Turner syndrome. On the other hand, we have the postductal, the adult type. There is narrowing distally to the ductus arteriosus, right? Distally to the ductus arteriosus. It's less severe and often asymptomatic in children. Collateral circulation develops over time in this case. Risk factors for CoA include Turner syndrome, bicuspid valve stenosis, We have by family history of congenital heart disease and neonatal conditions requiring prolonged ductus arteriosus patency. Clinical manifestation we could have the severe coarctation of aorta and mild or moderate coarctation of aorta. So we have high blood pressure before a point of coarctation. That is the most characteristics. Notice the coarctation of the aorta in this region, right? The narrowing of this aorta. So we're going to have high blood pressure before this point, right? And then less. Then you're going to have low blood pressure beyond the point of coarctation, right? So we normally do blood pressure measurement. So the increase in BP in the upper extremities and decrease in lower BP could be characteristic of this condition. Echocardiography Doppler will confirm the narrowing and evaluate associated defects like the bicuspid aortic valve. Chest X-ray. So we will see the rib notching due to collateral circulation, and you can see a figure 3 sign, that is indentation of the coarctation site, right? MRI and CT scan angiography is the gold standard for precise anatomical assessment before surgery. Management, we have neonatal, of course, it's a neonatal emergency in the cases where we have severe coarctation of aorta. Prostaglandin E1 infusion, this helps keep the patent ductus arteriosus open to maintain systemic perfusion. The use of inotropic support like dopamine, dobutamine for heart failure, surgical repair or balloon angioplasty will be required urgently. Definitive treatment is normally the surgical resection with the end-to-end anastomosis. This is preferred in neonates and infants. Balloon angioplasty plus stent placement will be preferred in older children and adults. And then post-treatment monitoring, you have to know that you are going to be on lifelong follow-up due to the risk of recoarctation, hypertension, and aortic aneurysm formation. Complications include hypertensive crisis and stroke if left untreated, aortic rupture and dissection, heart failure due to chronic left ventricular overload, and persistent hypertension even after repair. Ladies and gents, we are done with the coarctation of the aorta. You can attempt the free quiz on coarctation of aorta. Share your feedback and let's see how you performed in that quiz. The next cyanotic congenital disorder is aortic stenosis, abbreviated as AS, right? AS. AS is a congenital or acquired narrowing of the aortic valve, and this normally leads to left ventricular outflow obstruction and increased left ventricular afterload. The narrowed aortic valve normally restricts blood flow from the left ventricle to the aorta. So increased left ventricular pressure is going to lead to left ventricular hypertrophy, and this is just to compensate for the increased resistance. So over time, left ventricular dysfunction and heart failure might develop. Causes of this congenital aortic valve stenosis could include bicuspid valve, aortic valve, which is the most common congenital cause, or unicuspid or diplastic aortic valve, although this is less common. Other risk factor causes are genetic conditions like the Turner's syndrome. The clinical manifestations, we're going to have those with infants with the severe aortic valve stenosis are going to present with heart failure, poor feeding, and respiratory distress or shock. For children or adolescents, they are going to present with exertional dyspnea, chest pain, syncope, and fatigue. Patients with diagnosis of this aortic valve stenosis are going to present with a characteristic murmur where they're going to have systolic ejection murmur at the right upper sternal border, this radiating to the neck. They're also going to have weak peripheral pulses and delayed carotid upstroke, that is pulsus paravas tardus in severe cases. If you want to diagnose aortic valve stenosis, you could do the echocardiograph, which is the gold standard. So you assess the valve anatomy and pressure gradient. You could also do an ECG, where it will show signs of left ventricular hypertrophy, and also do chest X-ray, which will show the post-stenotic aortic dilatation. On management, you could look at the neonatal aortic valve stenosis. So these are critical aortic valve stenosis. We could do the prostaglandin E1 infusion just to keep the ductus arteriosus open. And we could also do the balloon valvuloplasty, which is the first line for congenital aortic stenosis. And then the surgical aortic valve replacement for severe and responsive cases. Then Ross procedure. This is used to replace the aortic valve with pulmonary valve in children. Complications of the aortic valve stenosis include heart failure due to left ventricular hypertrophy and reduced cardiac output. Aortic regurgitation, this is majorly post-intervention complication. And in severe untreated case, we could have severe or sudden heart cardiac death, right? The last cyanotic congenital heart defect is pulmonary stenosis. This is a congenital narrowing of the pulmonary valve or the right ventricular outflow tract. And this leads to right ventricular outflow obstruction and right ventricular hypertrophy. So, the narrowed pulmonary valve restricts blood flow from the right ventricle to the pulmonary artery, leading to increased right ventricular pressure, which leads to right ventricular hypertrophy. Severe cases may cause cyanosis due to the right to left shunting through the patent foramen ovale or atrial septal defects. So we have different types of pulmonary stenosis. We have the valvular pulmonary stenosis. Then you have the subvalvular, right? So the subvalvular and the supravalvular, right? So valvular PS result is the narrowing at the aortic valve, and this is the most common, right? The valvular pulmonary stenosis. Subvalvular or infundibular pulmonary stenosis starts from narrowing below the valve, often seen in the TOF tetralogy of Fallot. In supravalvular PS result narrowing above the pulmonary valve. This is less common. So patients are usually asymptomatic or present with mild exertional dyspnea for mild pulmonary stenosis. Patients present with exertional dyspnea and fatigue dyspnea and cyanosis syncope for the moderate to severe pulmonary stenosis. Patients also present with harsh systolic ejection murmur at the left upper sternal border with radiation to the back. And we also have wide splitting of the second heart sound. And this is due to delayed pulmonary valve closure. In terms of diagnosis, we have echocardiography, which is the gold standard. This one measures severity and valve gradient. ECG, which may show signs of right ventricular hypertrophy. So we're going to have tall R waves in the V1. Chest X-ray, that is, will show stenotic pulmonary artery dilatation. In terms of management, the first line treatment for valvular pulmonary stenosis is balloon pulmonary valvuloplasty, while for severe and the subvalvular pulmonary stenosis, we do surgical pulmonary valvotomy. For neonates with critical pulmonary stenosis, to maintain ductal patency, we give prostaglandin E1 infusion. Complications of pulmonary stenosis include right ventricular failure due to chronic pressure overload, arrhythmias due to right ventricular hypertrophy and dilatation, and cyanosis if the right to left shunting occurs. Ladies and gents, we have come to the end of the acyanotical conditions. These are conditions which were resulting in shunting from the left to the right, and cyanosis was not their major presentation unless if they complicate, then cyanosis happens. So conditions where cyanosis normally happens are the cyanotic heart defects, which include the T's, right? You have the tetralogy of Fallot, transposition of great arteries, tricuspid atresia. You also have the total annulus pulmonary venous return. I think the only conditions without T is now the hypoplastic left heart syndrome, right? Okay, which is refers to the underdevelopment of the left ventricular side. So starting with the most common cyanotic congenital disorder, and this is the tetralogy of Fallot. The exact cause is unknown, right? And possibly it is multifactorial. So this condition is characterized by four major conditions. We have ventricular septal defect, right ventricular outflow tract obstruction, that is pulmonary stenosis, right ventricular hypertrophy, and dextroposition of the aorta with overriding ventricular septal defects. So this is the most common cyanotic congenital heart disorder. It's characterized by the combination of the four defects that we have mentioned. So in terms of pathophysiology, there is right to left shunting occurring before due to the ventroseptal defect, pulmonary stenosis leading to cyanosis, blue skin, lips, and nails. Patients do present with hypoxic spells. We refer them as the TED spells. These ones can occur especially during crying or feeding, and when that happens it leads to sudden cyanosis, breathlessness, and loss of consciousness. So squatting position normally improve these symptoms by increasing systemic vascular resistance and reducing the right to left shunting. Patients with the TOF are going to present with TED spells, delayed growth and development. Exercise causes dyspnea, so they have to squat immediately. They're going also to present with systolic ejection murmur due to pulmonary stenosis. Remember the hallmark oscillatory finding of TOF. Tetralogy of Fallot is systolic ejection murmur at the left upper sternal border. These patients present with TED spells. These are episode of acute cyanosis caused by increased right to left shunting due to exertion or agitation, right? Or agitation. Remember, the most common clinical presentation for TOF is cyanosis, right? Cyanosis. In terms of diagnosis, we could do echocardio, which confirms the four defects. The chest X-ray of a patient with a TOF, it normally classically shows a chest X-ray classic of a boot-shaped heart due to the right ventricular hypertrophy, right? Right ventricular hypertrophy. ECG will shows right ventricular hypertrophy, right? So remember, which position helps relieve cyanotic episode in children with TOF? Squatting position. Don't forget that, right? Don't forget that. So you could do oxygen therapy for acute cyanotic spells. beta blockers to reduce TED spells, and IV fluids and morphine in severe cases. The definitive repair involves open heart surgery, usually in infants, to correct the defects, right? This is the definitive treatment of tetralogy of Fallot. For palliative surgery, we could do the Blalock tossing shunt, which may be done before complete repair. Palliative surgical procedure for TOF, remember it is the Blalock tossing shunt. Ladies and gents, the second cyanotic congenital defect is the transposition of aorta. This one is a cyanotic congenital heart defect in which aorta and pulmonary artery are switched. They are transposed. That is why we're talking of transposition of great vessels. Which vessels? Aorta and pulmonary artery. So they have exchanged position. This results into separate circulatory system that do not mix oxygenated and deoxygenated blood, making it incompatible with life unless a shunt mixing exists. So normal oxygen poor blood returns to the right hand and is pumped to the lungs via the pulmonary artery. Oxygenated in the lungs will be sent to the body via the aorta. But in the transposition of great arteries, the artery arises from the right ventricle, pumps oxygenated blood to the body, and the pulmonary artery arises from the left side of the and pumps oxygenated blood back to the lungs instead of the body. So without a mixing defect like atrioventricular or ventricular or patent ductus arteriosus, severe hypoxia and death can occur. So patients with this disorder are going to present with severe cyanosis at birth, tachypnea, loud single S2 sound, no murmur unless there is a ventroceptal defect or other defect is present. Metabolic acidosis due to poor oxygen delivery. In terms of diagnosis, we can do an echocardiography to confirm transposition of great vessels, X-ray that will show an egg on a string heart appearance, and then pulse oximetry will show severe hypoxia not improving with oxygen. The ECG will show right axis deviation and right ventricular hypertrophy. So to manage this condition, we need at least to keep the ductus arteriosus open to allow mixing of blood. We also do the balloon atrial septostomy. This one will create an atrial septal defect for better mixing of blood. The definitive surgical repair, that's the atrial switch operation, is referred to as the Jatin procedure. Jatin procedure is performed within the first 2 weeks of life to correct the transposition. Prognosis without treatment is fatal within weeks, while with surgery there is a high survival rate with normal development. The next condition is tricuspid atresia. Tricuspid atresia is a congenital heart defect characterized by absence or failure of development of the tricuspid valve, right? And this will prevent blood flow from right atrium to right ventricle. As a result, the right ventricle is going to be hypoplastic, that is underdeveloped. Circulation relies on the atrial and ventricular septal defects to allow blood to mix and reach the lungs. The tricuspid valve is absent, preventing blood from flowing into the right ventricle. The right ventricle is going to be small, that is hypoplastic due to lack of blood flow in it. So blood must flow through the atrial septal defect into the right atrium, mixing with the oxygenated blood from the lungs. Ventroseptal defect allows some blood to reach the underdeveloped right ventricle and pulmonary artery. If a patent ductus arteriosus is present, it helps supply blood to the lungs. Clinical features of a child with tricuspid atresia includes cyanosis at birth due to inadequate pulmonary blood flow. We also have rapid breathing and dyspnea, clubbing of fingers and toes in older children, murmurs due to associated ventroseptal or the patent ductus arteriosus, and single heart sound since the pulmonary valve may be absent or poorly developed. So it will be single instead of the double. In terms of diagnosis, you could do an echocardiography which confirms the absence of tricuspid valve and associated defects, X-ray which will show narrow or slightly enlarged heart, decreased pulmonary vascularity, ECG which will show left axis deviation and right atrial enlargement, and lastly pulse oximetry which will show hypoxia that does not improve with oxygenation. In terms of management, patient with tricuspid atresia could be given prostaglandin E1 infusion just to keep the ductus arteriosus open to allow blood flow to the lungs. You could also do or perform the surgical palliation, that is through a staged repair. So we could have the blood block tausin shunt in infants, which is going to help increase pulmonary blood flow. Also, bidirectional Glenn procedure, about 4 to 6 months, which will connect the superior vena cava to the pulmonary artery. The Fontan procedure, which is done at between 2 to 4 years, this one is going to create systemic venous return directly to the lungs. Prognosis without treatment result into high mortality in infants, while with the surgical repair, many patients could survive into adulthood with good quality of life. The other cyanotic condition that will present with cyanosis is the hypoplastic left heart syndrome, HLHS. This condition is characterized by underdeveloped left sided heart failure structures, including hypoplastic left ventricle, aortic atresia and stenosis, mitral atresia and stenosis, hypoplastic ascending aorta and aortic arc. The left side of the aorta is unable the left side of the heart is unable to pump oxygenated blood to the body, making survival dependent on the ductus arteriosus and atrioseptal defect for circulation. So, when the left ventricle is too small to pump blood systematically, blood returning from the lungs through the left atria must pass through the atrial septal defect into the right atrium. So, the right ventricle takes over the pumping action, sending blood to the lungs and systemic circulation via the patent ductus arteriosus. So, closure of the PDA will lead to circulatory collapse and death. Patients with this condition, hypoplastic left heart syndrome, are going to present with severe cyanosis, tachypnea, weak and absent pulses, single loud S2 heart sound, shock, and metabolic acidosis if left untreated. You can diagnose this condition through the echocardiography, which confirms left heart hypoplasia, mitral stroke aortic atresia, and right ventricular enlargement. You could also do chest X-ray, which confirms the cardiomegaly, pulmonary venous congestion. ECG shows the right ventricular hypertrophy and right axis deviation. Pulse oximetry will show low oxygen saturation and unresponsive to oxygen therapy. You treat by giving prostaglandin E1 infusion just to keep the ductus arteriosus open to allow blood to flow in the body. Avoid oxygen therapy because oxygen reduces pulmonary vascular resistance, worsening systemic blood flow. In the surgical palliation, you could do staged repair. We are going to have Norwood procedure for the neonates to create a systemic outflow tract using pulmonary artery. Glenn procedure where the superior vena cava is connected to the pulmonary artery, and the Fontaine procedure, which redirects systemic venous return to the lungs. We could also do heart transplant, which is alternative for patients who cannot undergo stage repair. Prognosis without treatment is fatal within few days of life. Lastly, we have the total annulus pulmonary venous return, the TAP VR. And this one is a defect where all pulmonary veins fail to connect to the left atrium, right? Total annulus pulmonary venous return, right? So instead, they drain into the right atrium or systemic venous circulation, leading to mixed oxygenated and deoxygenated blood. And we have T. Total annulus pulmonary veins return is classified based on the site where pulmonary veins drain. Like the supracardiac tap is the most common, like approximately in 50% cases. Pulmonary veins in this case drain into the superior vena cava via the annulus ascending vein. Cardiac tap, this presents about 20% where pulmonary veins will drain into the right atrium directly or via the coronary sinus. Infracardiac tap, about 20 pulmonary veins will drain into the portal veins, hepatic veins, or inferior vena cava. Lastly, mixed tap, that is about 10% pulmonary veins drain into the multiple abnormal sites. So oxygenated blood from the lungs bypasses the left atria and enters the right atria, mixing with deoxygenated blood. So the right ventricle pumps this mixed blood to both lungs and systemic circulation, causing cyanosis. An atrial septal defect is essential for the left atrial filling and systemic circulation. Severe pulmonary congestions and right heart overload can occur, especially in obstructed total annulus pulmonary veins return. Clinical features will include cyanosis at birth, tachypnea, signs of right-sided heart failure, poor feeding and failure to thrive, loud second heart sound, and obstructed tap, which is normally an emergency and presents with severe cyanosis, respiratory failure, metabolic acidosis. This condition requires immediate surgical correction. You could diagnose this condition using the echo, which is the gold standard, and this one will show abnormal pulmonary vein drainage and atrial septal defect. Chest X-ray will show classic Snowman sign, which is in the supracardiac type. ECG will show right ventricular hypertrophy, and cardiac MRI or CT scan will confirm the anatomy before surgery. For management, you do oxygen, ventilation, prostaglandin E1 infusion if ductal dependent, and surgical repair, which is the definitive treatment for the redirection of pulmonary veins to the left atrium and closure of the atrioseptal defect. Supportive care by the use of diuretics, inotubes for heart failure before surgery. So without treatment, this condition is fatal in infancy, especially if obstructed. Ladies and gentlemen, that's the end of congenital heart defects. Remember, we have talked of the acyanotic and the cyanotic one, those that present with cyanosis and no cyanosis, right? So, and all those were all congenital heart defects, right? Now, let's look at some of the acquired disorders, acquired heart diseases. Starting with rheumatic heart disease. This is a chronic heart condition that is caused by recurrent or severe episodes of acute rheumatic fever, leading to permanent damage of the heart valves. And the most common valves are affected is the mitral and the aortic valves. A complication of untreated group A streptococcus, that is the strep throat, which then leads to inflammation and scarring of the heart valves. So we have the group A streptococcus infection, right, leading to due to untreated streptococcal pharyngitis. So acute rheumatic fever triggers an autoimmune response leading to inflammation of the heart valves, that is the carditis. So over time, repeated valve damage result into fibrosis, stenosis, and regurgitation, leading to heart failure, atrial fibrillation, and embolic complications. Risk factors include recurrent streptococcal infections, low socioeconomic status and overcrowding, lack of access to antibiotics, family history of rheumatic fever, and living in endemic areas like the sub-Saharan Africa, South Asia, and the Pacific Islands have higher rates due to poor healthcare infrastructure and higher infection prevalence. In terms of signs or the clinical features, we have the mnemonic Jones, right? Jones, like the Jaws, JCNE. J for joints, where we're going to have due to migratory polyarthritis. C for carditis, pancreatitis, mammals, heart failure, and nodules, subcutaneous painless, erythema marginatum, patient going to present with rash, and synovium cholera, which is involuntary movement. So for the minor criteria, for the Jones criteria, the minor criteria includes the FEB, which is fever, elevated erythrocyte sedimentation rates, and C-reactive proteins, along with prolonged PR interval on the ECG. Diagnosis, clinical diagnosis, you normally do it by using the Jones criteria. Jones criteria, so we have evidence of preceding group A streptococcal infection plus a major or minor criteria. We could do throat culture, rapid streptococcal antigen test, which confirms the group A group of infection. Echo will assess valve damage, so we could look at if there is stenosis, regurgitation. ECG will show prolonged PR intervals, atrial fibrillation if it is severe. Chest X-ray could show cardiomegaly in advanced stages. So remember, Jones diagnostic criteria has the major criteria and minor criteria. So for acute rheumatic fever, we do antibiotic, that is benzathine, penicillin, to eradicate streptococcal infection, right? So this one is normally used to treat infection caused by gram-positive, cocci, particularly the streptococcal infection, right? We could also use the anti-inflammatory therapy, like the use of aspirin and corticosteroid for candiditis, supportive therapy for chronic rheumatic heart disease. Secondary prophylaxis for long-term benzathine penicillin injections to prevent recurrence. Heart valve repair or replacement if severe mitral or aortic stenosis, and heart failure management. So you use the diuretic, the beta blockers, the anticoagulants if is present. The atrial fibrillation. For prevention, primary prevention includes the early treatment of streptococcal pharyngitis with a penicillin drug, while secondary prevention includes long-term antibiotic prophylaxis to prevent recurrent acute rheumatic fever. That's the end of rheumatic heart disease. We can look at the Kawasaki disease. This is an acute systemic vasculitis that primarily affects medium-sized arteries, especially the coronary arteries. And this normally leads to coronary artery aneurysm if untreated. This condition is the leading cause of acquired heart disease in children in developed countries. So vasculitis affecting small, medium-sized blood vessels, potentially leading to coronary aneurysm. The exact cause of this disease is unknown, so it is idiopathic, but it is thought to be triggered by an abnormal immune response to an infectious agent in genetically predisposed children. So is going to cause widespread inflammation of blood vessels. That is what we're referring to as vasculitis, particularly affecting the coronary arteries. So if left untreated, it can lead to coronary artery aneurysm, myocarditis, and ischemic heart diseases later in life. The common risk factors include the age, where it affects majorly the young children under 5 years with a peak of about 1 to 2 years. It affects more boys than girls. And in terms of ethnicity, there's a high prevalence in the Asian population, particularly in Japanese and Korean children. See, in terms of season of infection, cases are more frequently reported in the winter and spring. In terms of clinical features, we could use the diagnostic criteria. So the diagnosis of this Kawasaki disease requires fever lasting more than or equal to 5 days, plus at least 4 of the 5 criteria are below, talking of conjunctivitis, the rash, mucosal changes, extremity changes, cervical lymphadenopathy. Remember, incomplete or atypical Kawasaki disease cases do not meet these full criteria, but still they have coronary artery involvement, so they should be taken seriously. Kawasaki disease is divided into phases. We have the acute phase, which is characterized by high fever, subacute phase, which presents with peeling of the skin, that is desquamation and coronary artery aneurysm, and lastly, the convalescent stage, where symptoms where patients have lab markers like the erythrocyte sedimentation rate and C-reactive proteins will remain elevated, and the coronary artery damage may persist in that 4th stage. So we have several complications associated with this one. You have cardiac complications, which are the most common, followed by coronary artery aneurysm, myocardial infarction, aneurysm, pericarditis, myocarditis, and heart failure. So you just need to look at diagnosis, which we look at clinical diagnosis, and is based on the criteria above tests. So we have elevated inflammatory markers like the C-reactive protein, the erythrocyte sedimentation rate, thrombocytosis, where we have increased platelet in the subacute phase, leukocytosis, and we have anemia, mild transaminitis, and the sterile pyuria, right? Sterile pyuria, where white species in urine without necessarily having an infection. Echocardiography is essential for detecting coronary aneurysm, and the baseline diagnosis repeated at the 2nd and the 6th week. So the first line treatment of the Kawasaki disease involves IV immunoglobulin, that is IVG, which reduces coronary complications, high dose of aspirin, that is ASA, that's anti-inflammatory during the acute phase, and low dose aspirin if there is no coronary aneurysm. Additional treatment includes the second dose of IV if fever persists, or corticosteroid or biologics like infliximab in resistant cases, right? Okay. So guys, we are done with Kawasaki disease. We can now attempt the free quiz on Kawasaki disease. The next acquired heart disease will be the infective endocarditis, right? Infective endocarditis is an infection of the endocardium, that is the inner lining of the heart valves, or implanted cardiac devices caused by bacteria, fungi, or other infectious disorders. So it normally leads to vegetations, that is clumps of microorganisms and inflammatory debris on the heart valves, and can cause serious complications like heart failure. So mostly it's caused by bacterial causes. So And for bacterial causes, we have viridans streptococci. This is most common in children with congenital heart diseases. Staphylococcus aureus seen in healthy children and IV drug use. And coagulase negative staphylococci associated with prosthetic valve endocarditis. Enterococci is common in older children with systemic infection. Fungal causes are very rare but serious, like Candida species, mostly in immunosuppressed or immunocompromised children. Risk factors for infective endocarditis include congenital heart defects, prosthetic valves, previous history of infective endocarditis, indwelling central venous catheters, like common in the neonatal ICUs and pediatric. IV drug use are less common in children but commonly seen in adolescents. Recent dental or surgical procedures without prophylactic antibiotics and immunocompromised states like chemo and HIV. So we normally have endocardial injury, which leads to bacterial adhesion and vegetation build up that result into embolization and tissue damage. Patients with endocarditis are going to present with prolonged fever, which is the most common symptom. And then we have now fatigue, malaise, anorexia, chills, night sweats. Cardiac symptoms like new and changing heart murmurs, signs of heart failure, dyspnea, edema are also very, very common. Diagnosis, we have blood cultures, at least 3 sets from different sites before starting antibiotics. Echo, so it will show vegetation seen on valves. We have the Duke criteria. This one is used for clinical diagnosis based on the major and minor criteria. Major criteria, we have positive blood culture for the typical infective endocarditis organisms, vegetation or valve on echo. Minor, we have fever and other factors. So for the treatment, you do supportive therapy, you give oxygen, IV fluids, and you also monitor for heart failure. Use of antipyretics for fever, empiric IV antibiotics, that is before culture results are found, so that you could give ampicillin plus genta or vancomycin if the methicillin-resistant staphylococcus are suspected. Prosthetic valve endocarditis, we could use vancomycin plus genta and rifampicin. So you need to adjust antibiotics based on the blood culture results. As for the surgical intervention, if needed, we could do valve replacement, especially for severe valve destruction or abscess, debridement of infected prosthetic valve. Prevention, we can have prophylactic antibiotics for higher risk children before dental or surgical procedures, amoxicillin for oral or ampicillin for IV before dental procedures in congenital heart patients. We could also do clindamycin if the patient is a penicillin allergic. Complications of infective endocarditis include heart failure, septic emboli, sepsis, and multiple organ failure, and abscess formation in heart failure. So that is all about infective endocarditis. So the next condition is myocarditis. Myocarditis is an inflammatory disease of the heart muscle, myocardium, right? The infectious organs, especially infectious causes, the most common one, we have the viral myocarditis, which is the most common. The Coxsackie virus is the most common viral cause. For the bacterial causes, we have the group A streptococcus and diphtheria, LIMS, and borrelia. Fungal and parasitic causes could include Candida species and Trypanosoma cruzi, the one that is found in Chagas disease. The non-infectious causes include autoimmune infection like mediated disorders like the Kawasaki, the lupus, the toxins, the post-viral, and the multi-system inflammatory syndrome.
So we have, in terms of pathophysiology, you have the initial injury, leads to inflammatory response, then the cardiac dysfunction resulting in chronic myocarditis that results into dilated cardiomyopathy if that inflammation persists. So we have early symptoms, cardiac symptoms, and signs of heart failure, and even severe cases presenting with cardiogenic megaly, arrhythmia, and sudden cardiac arrest. In terms of diagnosis, we have clinical presentation, we have unexplained tachycardia, heart failure, or arrhythmias. ECG, where we have non-specific ST segment wave changes, arrhythmias, and conduction abnormalities. Echo could show dilated ventricles, reduced ejection fraction, and wall motion abnormalities. Cardiac MRI, that is the gold standard for myocarditis, will detect myocardial inflammation. Blood test could show elevated cardiac enzymes, elevated inflammatory markers, viral serology for specific infection, and endomyocardial biopsy. For the management, we could do supportive care, oxygen therapy, and ventilatory support if they are in respiratory distress. So do IV fluids, of course, cautionally just to avoid fluid overload. And we could also use the diuretics like loop diuretics furosemide for heart failure symptoms. Advanced therapies, we could have the extracorporeal membrane oxygen for refractory cardiogenic shock and ventricular assist device to bridge to recovery or heart transplantation. Remember, extracorporeal membrane oxygenation is a machine that temporarily takes over the function of the heart and the lungs. Complication, you could have dilated cardiomyopathy, severe arrhythmia, cardiogenic, and thromboembolism in that case. So all those are examples of acquired heart diseases. The others include cardiomyopathies. So could have dilated cardio, hyper, restrictive, cardiogenic, but the most common one in this case are dilated and hypertrophic cardiomegaly. Diagnosis, you could do an echo to look at chamber size, contractility, or ECG arrhythmias, conduction defects, cardiac MRI for structural abnormalities, or the genetic testing important for these HCM and ARVs types. Heart failure therapy, so you give diuretics, beta blockers, AAC inhibitors, antiarrhythmic therapy, or implantable cardiodefibrillator, that's ICD for high risk arrhythmias, and heart transplant in severe cases. For the arrhythmias, pediatric arrhythmias, of course, the common pediatric arrhythmias include the sinus tachycardia, supraventricular STD is the most common symptomatic arrhythmia in infants. You should know that. Then ventricular tachycardia, QT syndrome, which risk the baby developing the torsades de pointes and complete heart block. So you could do ECG, the Holter monitoring, or the electrophysiology study. Maneuvers like vagal maneuvers, adenosine for this SVT, which is the most common, beta blockers for ICD, and the pacemaker for the heart blocks. For the pericarditis, we are looking at causes like the influenza, the Coxsackie virus. If it is bacterial, then you suspect TB, or sometimes it can be autoimmune disease like in the juvenile idiopathic arthritis or SLE, then post-cardiac surgery, like in the post-pericardiotomy syndrome, all right, some of the suspects. So the patient presents with sharp pain, pericardial rub, tachycardia. It can be diagnosed through the ECG, which shows diffuse ST elevation and PR depression, echocardiogram, pericardial effusion, and cardiac MRI, which detects pericardial inflammation. So we treat using the NSAIDs, colchicine to reduce inflammation, corticosteroid for autoimmune pericarditis, and pericardiocentesis if there is large effusion causing cardiac tamponade. The other condition is pediatric hypertension. So this is defined as greater than or equal to 95th uh, percentile for age, sex, and height. So we could have essential, which is common in obese children, or secondary, which could be due to a renal disease, coarctation of aorta, or endocrine disorders like Cushing syndrome or hyperthyroidism. All right. So the best diagnosis we could do ambulatory BP monitoring, renal ultrasound if secondary cause is suspected, lipid profile and fasting sugar if they are obese. Management, you do lifestyle and use of the anti-hypertensive drugs. The other one is pulmonary now hypertension. Remember the other one was pediatric hypertension, and this is pulmonary hypertension defined as increased pulmonary artery pressure leading to right heart failure. Causes could be congenital heart diseases, persistent pulmonary hypertension, chronic lung diseases uh, uh, as uh, as the causes. The clinical features could include loud P2 pulmonary valve closure, right right ventricular hypertrophy on the ECG. For the diagnosis, you could do echocardiogram, which estimates pulmonary artery pressure, and right heart catheterization. For management, we focus on improving oxygenation, reducing pulmonary vascular resistance, and preventing complications. So, oxygen therapy, which will help reduce pulmonary artery pressure and prevent hypoxia. Vasodilator medications like sildenafil, which is a phosphodiesterase 5 inhibitor, and bosentan, which is an endothelium receptor antagonist, will help improve blood flow in the lungs. Lung, lung transplantation is considered in severe treatment resistant cases when other therapies have failed. The last condition here is early onset atherosclerosis. So atherosclerosis in children can begin as early as the age of 3 and can lead to cardiovascular diseases in adulthood, right? In adulthood. So fatty streak made of cholesterol and its esters will build up in large arteries. These streaks can increase after age 8. In some cases, the streaks harden into fibrous plaques. These plaques can rupture, which can lead to stroke, heart attacks, or other cardiovascular diseases. So the causes include genetic factors, obesity, diabetes, hypertension, sedentary lifestyle, and poor diet. Clinical features, this is usually asymptomatic in early life, but you could have cholesterol deposit in skin or tendons, which is referred to as xanthomas, in severe hypercholesteremia. Early coronary artery disease like angina, MI in teens or young adults. Diagnosis, you do lipid profile. So you're going to have elevated low density lipoproteins and low high density lipoprotein. Carotid edema thickness. So ultrasound. Management, you do dietary modification. So you encourage low fat and high fiber diet. You can use statins in higher risk cases, right? Statins, remember, they are also referred to as HMG CoA reductase, and also encourage physical physical activity. So, ladies and gents, you should know that congenital heart diseases affects almost 1% of live births globally, and it's a major cause of infant mortality. The rheumatoid heart diseases, this one causes about 300,000 deaths annually, and it has highest prevalence in sub-Saharan Africa. Kawasaki disease is the leading cause of acquired heart disease in children with increasing global incidence. Pediatric hypertension is rising due to obesity, prevalence increasing worldwide, including our country, Kenya. Cardiomyopathies, we have significant cause of heart failure, and it contributes to the high burden in low-income countries, and this is due to late diagnosis. Infective endocarditis affects children with pre-existing heart conditions, high mortality if untreated. Arrhythmias can cause sudden cardiac arrest and is often underdiagnosed in low and middle income countries. Pericarditis is characterized by we have a high burden in Africa, and this is due to infectious causes, particularly tuberculosis. Pulmonary hypertension normally leads to right heart failure, and it's worsened by chronic lung diseases like the COPD. Lastly, early onset atherosclerosis is increasing. It's increasing in children due to childhood obesity and diabetes, especially in urbanized areas. So, ladies and gents, that brings us to the end of our presentation on pediatric cardiovascular disorders. In this session, we have covered congenital and acquired heart diseases, their pathophysiology, clinical presentation, and management. I hope that you find this presentation useful. So please like our presentation, share our presentation with others, and subscribe if this was helpful to you. Always stay passionate about saving the life of young children. See you in the next session. Bye bye.